Welcome to Reducing the Pucker Factor podcast, presented by the Blakery Content, the show to make every EMS and critical care provider feel sharper, calmer, and more prepared when the pressure is high and the patient is small. Here, we're going to dive into real conversations that matter: pediatric readiness, high stakes, decision-making, pre-hospital innovation, and the human side of caring for kids and families in their most vulnerable moments. From the scene to the sky, from the med unit to the helicopter, this is where EMS meets clarity, confidence, and community. Whether you're an EMT, paramedic, nurse, or flight clinician, our mission is simple: reduce the pucker factor. One practical insight, one expert guest, and one powerful story at a time. But before we get started, a quick reminder: the content in this podcast is for educational purpose only. Always follow your local protocols, policies, and procedures, and practice within the scope allowed by your state and your medical direction. Every system is different, every patient is unique, and your agency's guidelines always take priority. Now, take a deep breath. Let's get ready to turn that chaos into confidence. This is Reducing the Pucker Factor podcast. Let's get into it.
For the medics in the front line, let's go. For the flight teams on the lifeline, let's go. For the ones who are running faster, we're reducing the pucker factor. We're reducing the pucker factor, turning fear into confidence. From the med unit to the helicopter, bring the calm when the chaos won't stop. Yeah, we're the Blakery content crew, leading what the pros now do. Turning fear into calm under pressure. Pucker factor, gone forever.
Hey everyone, welcome back to Reducing the Pucker Factor, the podcast where we take high-stress pediatric emergencies and reduce the chaos into something you can actually manage. So today's guest is someone who's spent over 3 decades at the sharp end of respiratory care, from critical care units to the back of 911 trucks. So Kyle Goodnight is with us here. He's a registered respiratory therapist turned paramedic and clinical educator with Delaware County EMS in Ohio. So he's someone who didn't just ride the evolution of pre-hospital medicine, he's actually helped build it. From that early CPAP implementation to the rollout of EZ-IO, and now pushing one of the biggest gaps in EMS forward, that pediatric CPAP in the field. He's a national speaker, an innovator in airway and respiratory care, and someone focused on one simple mission: getting EMS providers to recognize respiratory failure sooner and intervene better. So Kyle, welcome to the show.
Thanks, Chris. I really appreciate it. Thanks for having me.
Yeah, absolutely. So one of the things that I like to do here is, before we kind of get into the deep end, I want to start out where we always do here with some quick hits. So no overthinking, just one word, one sentence.
In the
just
back of
your
the medic
initial
or
instinct.
in the back of the chopper. Okay, give me an answer.
Yeah.
I need to go. Okay.
Yep.
Cool.
Yeah. So RT or paramedic, what shaped you more?
RT.
Airway management, is it an art form or an algorithm?
Yes. It's a lot.
Yeah.
I just talked about that on one of the podcasts I had, that the BVM doesn't stand for basic ventilatory maneuver. There's a lot of stuff you have to think about just before you even get to touch the bag, so.
Yeah, absolutely.
But then once you touch the bag, then there's the art form. So yeah, so it's both.
Right, a little bit of both. So give me your don't miss this. What's the earliest sign of pediatric work of breathing EMS providers often overlook?
Just the importance of the retractions.
Yep. What's harder, teaching the skill or changing the mindset around treating kids aggressively?
Mindset all day long. That's my main focus on all my education now. It's all about the mindset. It really is, especially in this category. I mean, we'll get into it. It's huge.
Yeah. So hospital or street, where do patients fall through the cracks?
Probably hospital or street, where do patients fall through the cracks? Wow. It could be a combination depending on what hospital you take them to and how aggressive your department is. So it's a little bit of both. I'm a big believer in not stay and play, but stabilize before we transport. So if we're not stabilizing, then it's dropped on the hospital. And there was a great article someone put out the other day and shared it. It was an NEMSP article that talked about how long it takes for someone to get care at a hospital, even when they're brought in by a medic. So I think the cracks could be in that gray area where we're not doing what we need to do because we know what we can do. We have a protocol, but because we're like, oh, we're so close to the hospital, they can do it. and then they don't do it for a while, and now we're an hour behind. And that's what happened with my daughter when we get to that. We didn't have the answer, and she fell through the cracks because she was even taken to a normal room. And then when the doctor laid his eyes on her, he rushed her to a trauma bay and started the full gamut. So yeah, a little bit of both. Sorry, long answer to it. That's a complicated question. It really is. Being on both sides of the fence, I've for the first year of my EMS career, I worked full-time respiratory therapy in a busy ER. And I work full-time 24-hour shifts on the medic that I would bring in my patients, and then next thing 4 hours later, I'd be working on them still in the ER, that kind of thing. So it's a fine line. It's a a unique situation to be in. You've been in it. So.
Yep, absolutely. So that's kind of the rapid fire part, just kind of open up and kind of get things going here.
Did you see how I tried to not let it be rapid fire? I wanted to expand on things.
Right. Yep. And we're going to continue to expand. Yeah. So, but let's slow down for a second, right? And let's go to kind of where all the things start to fall apart for a lot of providers. And we say that we assess respiratory distress, but I think what we're really doing most of the time is reacting late or not really reacting, right? So let's get into that and recognizing that pediatric work of breathing. So I guess starting out, how do you define work of breathing in a way that actually translates to what EMS providers are going to see in the field? And then when you walk into a scene with a sick kid, what are you actually looking for first before you ever even touch them?
Right. When it's all about the triangle, we can see color. I was taught early on, even in respiratory, that there's a lot you can tell on the approach. As you walk into a room, as you walk into a home, you're gathering information. Even if it's a home that's like, let's just say an adult fall, and the house is disheveled. You're like, okay, well, this person, there could be more things going on than just this fall, with the way the house looks. So gathering that information as you walk up to them, specifically about pediatric respiratory distress, of course, you're seeing their color. You're hearing if they're crying. Of course, any kid, if I hear crying, I'm happy. I am a happy man if a respiratory distress child or any pediatric run, they're crying, because at least I know I got an airway. How deteriorated that airway is still yet to be seen. But as we walk up to them, that color, and then, once again, if we have a weird color or a gray color, we can start oxygen, we can start bagging. We had an answer for that one. Then when you go over to work of breathing on that triangle, we can say, oh, look, there looks like they're using their muscles. They may be grunting. They may be hidden by clothes. So expose that child. Once you get your hands on that child, expose them age appropriately in the right manner to see what their chest is doing, what their belly's doing. You can see nasal flaring as you walk up to them. So those are all cues that we have increased work of breathing. And then we just moved on to circulation. I'm like, well, they got a pulse, or, I felt for the brachial. Okay, I got a pulse. So I've got all of those things, but their work of breathing is where I can't fix because I have blow by, or I start blow by. And once again, a really, really good recent, approach at blow by is basically it does nothing. It exchanges dead air. You may be able to get a little bit of pulse ox, increase from it. It's not effective to decrease true work of breathing when it's advanced. So, but when it comes to what we can do about that part of the triangle, we never really had anything. And now we do. You could have bagged them if they were that far down, like if they're ready for impending failure, you could, of course, start bagging them. But that's about, you had two drastic measures: blow by that doesn't do anything, or intubation and bagging, and you never had that middle ground. So that's important to me, to recognize that work of breathing and understand that we can look at kids just like we look at the work of breathing of adults and say, hey, we've got an answer for this now.
Yeah. So that brings up a good question, right? Is we kind of walk through, or I guess, can you maybe walk through, are there any pediatric physiology changes that, maybe changes the way that we're assessing their breathing compared to adults? Or is it on the assessment side, pretty much the same thing that we're doing for adults and we're just not comfortable with it?
No, it's a little bit of both. I mean, boy, I'm saying that a lot, but because it's so much more than just, they're not exactly like adults. They're not going to be leaning over and doing that postural breathing. They're not going to be most of the time. And maybe the older children or a teenager could be pursed lip breathing. They're generating that auto peep. They're generating that back force to give them some auto peep. And kids don't do that, especially the younger ones. They'll be grunting, and that is the answer for what you would see in an adult as auto peep and pursed lip breathing. You may see a little bit of an older child starting to do that postural breathing, letting that chest help them and that diaphragm help them, bring that air in. And when it comes to exactly, what that means between adult and a pediatric patient, we're not going to have that quintessential sign of rails. We may, they're not going to be a child's not going to be a CHFer. So you have to, the mindset has to change. You have to be trained what work of breathing is and what CPAP or bilevel or BiPAP can do for that work of breathing in that child. And it's a little bit different than the adult. Now, being able to have something that fixes it is the exact same thing as what we have as an adult. So we had some comfort levels that we had to get over in the early days of EMS CPAP, and now we're super comfortable with it 20 years later, right? It is something that it's almost, you can hear the patient from walking in and say, oh, this person's going to need CPAP, BiPAP, and start not just assessing, but start applying the therapy. It's no different. We just have to learn what triggers us to go down the path of putting that, non-invasive ventilation on that child. And the fact that the mask now it's not it's a total face, makes it way more comfortable and a lot more acceptable to the kids.
Yeah. So, what are some of those subtle signs, though, that separate a kid who's compensating from a kid who's about to crash?
When it comes to the compensation, the one thing that is a late sign is that pulse oximetry. So don't let pulse oximetry give you a false comfort because one of the last ones that my department put on and they were in the mid 90s, 94, but they were struggling to breathe, one word sentences, silent chest. And, so don't get comfortable with just, their pulse ox is fine. Cause I've heard clinicians say that too, when, hear about respiratory distress in children. I'm like, oh, tell me more about it. Cause that's what I always ask when someone comes to me, because they know, me and a couple of other people are kind of like the go-to people, the champions of this, in our department. People will often come up to us and tell us about a run or share with us to, either learn or just talk about it. And I always say, just tell me more about it. Tell me more about what happened. What did you see? What was their sats?
Paint
how
the
long
whole
were
picture.
they? Yeah. Paint the whole picture for me rather than that. And, the last time I had somebody do that, it was a newer medic. He'd been a medic a little over a year, and he's like, hey, we almost CPAP'd a kid the other night. I'm like, okay, cool. I'm like, tell me about it. And he told me about it. And then he apologized. He's like, I'm sorry I didn't CPAP him. I'm like, no. I'm like, hold on a minute. You did what we taught you. You assessed the patient. You saw some retractions, but they weren't enough to say, okay, right to CPAP. You did some critical thinking. So that's my big goal. My big goal with this whole project is to teach people and remind people that in these situations, you need to critically think. When it comes to when they crash, that's kids can hold. That's one thing that our medical director will say that, and a lot of medical directors is like, well, we don't need pediatric CPAP. Kids hold on for a long time. Well, do they? And when they hold on, how long is it? Do you know exactly when they're going to fall off? Can you really tell me where those studies are? You can't. So how about we just support them and just use caution with a non-invasive, once again, non-invasive. This is not an invasive maneuver. We are not putting, if someone's like, well, I can just bag them. Well, you try to bag a kid, not just put a face mask that looks like a snorkel on them, or an SCBA, that's going to be even harder. So it's one of those things where, we have to overcome the mindset and the doubt that that's just really, that was early on. That seems a little aggressive. Don't you think, Kyle? No, actually I don't. PEEP is PEEP. And I actually literally watched it work when I asked the team if we could put her on BiPAP moments before they started intubating her. And it turned her around in 3 minutes, and she had decent sats, but her pressure looked like crap. She looked like crap, and next thing you know, we stabilized her, and then we're able to focus on the other stuff.
Yeah, I think that's some of the teaching points that I really hit on a lot is that, right, we know that inadequate ventilation in pediatrics is a leading cause of cardiopulmonary arrest, right?
Correct.
So
Yeah.
we have to not only aggressively assess those patients, but we need to aggressively manage them and treat them. And I think that's where often we don't, because we're just not comfortable, and there is that thought process that kids hold on for a while and that they do well. But I think I don't think that we truly appreciate the impact that we can have on those kiddos by doing that early intervention, right? And I talk about that a lot with like steroids in the asthmatic patient, right? Like, yeah, you're not going to see those that outcome. However, know that you are having an impact. They may get discharged from the ED instead of having to be admitted or end up in the PICU because of the early interventions that you did. So that's something I teach all the time, is aggressively assess these patients and then aggressively manage these patients. And I know we briefly talked about this offline, where I talk about all the time about that error by omission.
Error by omission, yeah.
Yeah, where we create that, there's medication errors, but I feel like this is an error as well, because we're not giving them the treatment they need because we're not comfortable. We have that pucker factor. We're not confident in the treatment, or in this situation, we didn't always have the tools that we're going to discuss here shortly. So I think that is going to change the game, but I think we also have to, as you mentioned, change that mindset. We have to train it, we have to educate on it, and then it will just become second nature.
Yeah. Yeah. And
Hopefully.
yeah, exactly. And that's what the goal is. That is with the team that started this in Central Ohio, my very close friend, Rob, that you saw speak at Dr. Antebby, his event, he doesn't have the error by omission concept. What he talks about a lot is do no harm. We're supposed to do no harm. And if we don't do anything for these worker breathing children that are in that severe level, or that asthmatic patient in that moderate to severe asthma, if we're not doing anything, that actually can turn them around quickly, then we are doing harm. We're not doing no harm, right? So it's the same concept. It's the same exact, thought process. And to get that through the minds of the clinician, that diesel fuel isn't the answer, that stabilizing is the answer. And that's a big push right now. Stabilization in the field, because we have so many tools, we can have the education. You just have to be open to it and have to be and start applying it, And I know that these are low frequency, high acuity type of runs, but that's why training and getting the mindset change is going to change that. Because how many pediatric, 18 or younger asthma patients do we see? A lot more than we see that crumping little baby, but still, it's still the same concept, the same decision tree.
Yeah. All right. So we've identified a problem, right? We're seeing it earlier, hopefully, at least we should be. But the reality there is that recognition without action doesn't really change outcomes, right? So let's talk about that intervention that, pediatric CPAP that we've mentioned here. And why EMS has been slow to embrace that.
I think they've been slow to embrace it, just from the comments that I've heard as we have brought this through. It's been working in the hospital setting for decades, right? I mean, my daughter's 21 years old. When that day that she got put on BiPAP in the trauma bay with her respiratory distress issue, she was 7 years old. So we're looking back at 2012 timeframe, and we just so it's been, and then we didn't get it implemented here in Central Ohio until 2019, right? 18, 19 when the team started working on it, and then got it implemented with the protocols and everything, and on a couple of the different trucks, and now it's spreading, it's spreading decently through Central Ohio, and now hopefully around the country with the new spark of interest. COVID really hurt the forward momentum because that 2019 implementation literally, I think I remember when we went to our city council to talk about this with the department that put it on their trucks first, and that was about a week or two before they shut the world down. So it was COVID killed all CPAP for the most part because people wanted closed systems. So especially when it came to peds, so we didn't get the push that we're having now with all the exposure and just the what we should have had 7 years ago. So when it comes to actually implementing it, though, it was we had to come up with a way that what we saw that works in the hospital can work in the EMS. So we had to come up with parts and pieces to Apollo 13 it together, you know what I mean? And then the training. So, when it comes to how that was implemented and how that all came about, protocols are important. Those have been changed and rectified and fine-tuned and looked at it, folks like Dr. Antebi and Dr. Kadish and Dr. Lowe here locally, and we've really got something good when it comes to a protocol. So all of that stuff, which also stops people from putting something into play, like, man, I don't want to have to draw the protocol from scratch. Well, we've got it. We've got a sample protocol that's been approved by pretty big names. Let's go. Here it is. We're not trying to do anything but just give you all the answers that is being successful with us. And
So I think stepping back then at a fundamental level, what does CPAP actually do? How does it work? How does it function? And specifically support our pediatric patients in respiratory distress?
Well, and CPAP, BiPAP, like I said, when my daughter went on it, it was truly the BiPAP machine at the hospital. So you have that two different you have bi with two different levels of pressure. So your inspiratory assist pressure, and then your expiratory resistance pressure per se. PEEP, positive end expiratory pressure, can be generated, like I mentioned before, just by pursed-lipping your breath. It can also be generated by sticking your head out of the window, going 100 miles an hour, and opening up your mouth and breathing against the flow. So we have flow devices out there, and we have mechanical devices out there. Some of the mechanical devices are inside of machines, like ventilators. So that resistance of breathing out gives you that positive end expiratory pressure that helps extend the alveoli open. And whether that's PEEP or BiPAP, that part is the same, allowing for more surface tension and surface area for everything to cross over properly and support their breathing when, and even with a true CPAP device, there's still flow. I mean, so when they take a breath in, they're having some resistance. It's just not a trigger of extra flow, when it comes to a bi-level. But both of them work, and both of them are, in my opinion, the disposable devices are those acute answers to the problem right now to stay and stabilize. And then it doesn't mean that you can't, when someone starts somebody on CPAP in the EMS system, and let's say it's a disposable device and they don't have ventilators on their truck, and then they get to the hospital will upgrade them to their device, right, to their machine. And that's no different than what we can do if we have disposables or whatever type of CPAP. If we now have access to a BiPAP inside on a ventilator inside the truck, we can now upgrade that person to the next level of care up above, and then get them to the hospital, and then either pass on that care or give them the next level that way. So the mechanism of PEEP and holding those airways open is really how it works. PEEP is PEEP. Whether you're 5 grams or 500 pounds, it still does the same things to the lungs that it does on an adult to a pediatric. So if you have wrapped your head around what CPAP and BiPAP bi-level can do for an adult, it does the same thing on the pediatric, including all the way down to the neonatal size. I know you have probably transported neonatal people on CPAP nasal pillows, and that's the thing. It's been done. It's been being done in hospitals and inter-hospital transports for years. There's really no reason why we just can't take the same philosophy and just train our people and give them the equipment that makes it work.
Yeah, absolutely. And I think what that reminds me of is the pre-hospital blood, right? Where it's been happening in the hospitals for extremely long time, and we're now getting to that point where we've broken down those barriers, we're doing the education, we're putting those things into place, and I think this is kind of following that same path or trajectory there, right?
Yeah, exactly.
So I think that's another good question, though. But what does early CPAP change in the trajectory of these patients before they even hit the hospital?
It changes I mean, we're actually in the middle of doing the retroactive look back at all the patients that we've had in Central Ohio, where we'll have a paper on that eventually. We're in the IRB stage of it. But as we talk to our medical director, who knows intimately about some of the cases that she's either worked on or she's reviewed for the departments that she's a medical director with, they've found shortened ICU stays. Some patients are getting discharged from the ER after they've been stabilized because of early intervention and early, stabilization and early, steroids. So, that's kind of the hypothesis right now, is that there are definitely less admissions, definitely less ICU stays. They could still be going to the ICU. My daughter went to the ICU, but and stayed there for a day and a half, 2 days to stabilize everything about her. So it's one of those things where what we're seeing on the early, scratching of it, and the people that are dealing with these patients directly, we're seeing less hospital stays and better outcomes as a whole. We're just trying to we are definitely in the process of getting the actual, feedback on that. So yeah, that's what's important, is to eventually have that for everybody to see.
Yeah. So how early is early enough? So when should CPAP realistically be considered on scene?
In my opinion, it's all based on what you're looking at, that work of breathing. If that work of breathing is, if you've got that substernal retractions, that baby is, or that kid is sucking, in at the bottom of their sternum all the way to their back of their chest, they are working hard. If they look like they're working hard, we have something that can give them some support or give them total support. So that work of breathing is really key. I mean, if I, in my webinars and in my lectures, I tell people, if you are tired of hearing me say work of breathing by the end of this, then I did my job. It's just same thing when I train high performance CPR. If you're like, okay, dude, I know it's about the pauses. For the love of God, stop talking about pauses. I'm like, okay, I did my job. That's what I need to do. I needed to get it through their brain that don't pause, or pause as little as possible. Same thing with this work of breathing. If you're assessing that kid and you're like, and you have that pucker factor, let's go ahead and bring in the name of your, looking at the pucker factor. If you're like, oh my gosh, I normally would have grabbed this kid and run to the back of the truck and said, go, 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 and my driver doesn't even get out. That's like, hold on a minute. We can stabilize this patient when we have this treatment in our protocol and in our system.
Yeah. Now, so if pediatric CPAP became standard practice tomorrow, what would change in outcomes across EMS systems, you think?
Hospital stays, potential cardiac arrest from respiratory distress. I think it would. Here's one factor that we often forget about, and I said it in my podcast. What is mental health of us? Our anxiety on scene of a pediatric patient. We all know that pediatric patients aren't as frequent as adult patients. There could be some of us that are cool, calm, and collected with peds because we see more of them than others. But the majority of us don't see them as much as we should. So our mental health is a huge thing that could benefit from this as well, because I miss my daughter's respiratory distress. I'll be honest. When my daughter went down on us, I missed it. I didn't call the squad. I should have. I took her to an urgent care. Should have taken her to an ER. And then I was falling off of the ability to assess my own child until right before they intubated her. I was like, you know what? Hold on a minute. We've got something that can fix this without intubation. Let's try it. 3 minutes later, we're going to find out if it works or not. So the mental health of those lack of decisions back then for me was damning. I mean, I remember even one time I was in an office of a chief because I was calling on their department, a different department. And he said, Kyle, you're not yourself. You okay, man? And I said, and I just broke down. I was like, no, dude, I'm not good. And I told him the whole story, and he got up, shut his door. Him and I had a very serious conversation. He had screwed up once in his life about, assessing a loved one and didn't get them the help that they needed originally. And it was, almost detrimental for them as well. And so when it comes to our mental health, knowing that we have something to fix these type of kids, that we don't have to look back and say, oh, that kid went into arrest because I didn't have the tools to help them breathe. Now, can somebody crump even if you have the tools? Absolutely. This is not the nothing is a smoking gun that fixes everybody, but it's at least something that we have in our toolbox that we can learn, implement, deploy, and know that we're doing we always want to do everything we can, right? For the most part, that's what I want to do. I can't speak for every EMS individual, but I hope that everybody wants to be able to do everything they can to stabilize that patient. And when we didn't have this option, diesel fuel and blow-by was a poor answer. Wasn't even an answer that should have even been addressed since how long we've been doing CPAP in the hospital setting.
Yeah. So you hit on a pretty important part there that I speak about in my lecture that I've been traveling around, the Reducing the Pucker Factor lecture. And part of that talks about provider confidence and preventing burnout, right? We know that these pediatric calls are the ones that are gonna stay with us. But I typically argue that the ones that stay with us are the ones that we felt we didn't do enough, or we could have done more, we could have done something differently. Where when you show up and you have that call where you rocked it, right? Like you felt confident, you hit all the things, even if the outcome isn't necessarily what you wanted, but that you gave everything that you possibly could, you walk away from that as a different person.
Absolutely.
Those ones, they sit with you, but in a different way. They don't weigh you down.
I can name 5 right now.
Yeah. And so that's where those really, and one of the things I say in there is, if you know that your agency has your back by, one, providing the education and training and equipment, right, and resources, it really changes the game for you. And I think that's exactly what you just hit on there, is addressing those. And it does prevent that provider burnout, protects our mental health, and also it ensures that the pediatric patients are getting the treatment that they should be getting.
Right.
And not be an afterthought, or, just getting treated with diesel or treatment by proximity, right? We're only 5 minutes away. The hospital can do it. But, as you mentioned earlier, the article, just because they go through those ER doors doesn't mean they're getting treated immediately. So,
right.
But I think maybe before we transition into like the implementation and how we can actually roll this out, if you're okay with it, I would love to hear the story of your daughter and your interaction and what kind of brought your passion into this, if you're okay with that.
Sure, absolutely.
Okay.
It can be a TED Talk, or it can just be the highlights. So it's a tough one, and I'll get emotional, but that's part of it. That's why this is so passionate for me and the team that's dealing with this, because the parts of the team that have been integral in this were people that were there that night, that came and visited my daughter. So my son, we really need to start 3 days earlier. My son is a 10-year-old croup kid, and he came. My wife brought him up to the medic. He doesn't look good. I need you guys to evaluate him. My lieutenant looked at him. He said, we're going. So we went off to the hospital. He was 10 years old, holding his airway just fine. Definitely the croupy cough, just not looking good. Got him to the hospital, turned him around. He got discharged. Well, 3 days later, my daughter went down with it. And then in the middle of the night, she started puking and having diarrhea, which also brought her further down, when it came to her electrolytes and whatnot. So when I was at home that day. My wife had just started a new job as a nurse at a pediatrician's office. She's a pediatric nurse. It's like all the Jesus Lord, what are you doing to me? But so when she had a rough night. And I let her sleep as long as I could, and then I turned on the lights a little before noon, and I took one look at her, and I did recognize that, okay, she doesn't look good. This is not what a normal sick kid looks like. So I'm like, text my wife, hey, taking her to the urgent care. So I drove 25 minutes south of where I lived at the time to our children's urgent care. Well, that nurse took one look at her and called the squad and yelled at me, so, and I'm like, what, but I mean, at the time, I mean, honestly, other than, getting her down earlier to the main children's hospital, that was an additional 25 minutes from where we were at when we went to the urgent care, that those medics didn't have the fix. The medic that she called didn't have the fix. My wife rode with her down to the hospital, and those medics had their hands tied. Hey, we'd like to start an IV. Oh, okay, please do. We'd like to put her on some oxygen. Okay, please do. But that was it, and it didn't turn her around. So they get to the hospital. She gets put into a regular room, not an acute room. Dr. Larson, I'll never forget him, and a shout out to him. I think he's at Dayton Children's now. I've been trying to get a hold of him to share with him that he's an integral part of this story. But he took one look at her, unlocked the bed himself, grabbed her, started pulling her out of the room on the cot, and said, "Mom, Dad, give me the last 12 hours. I need to know everything." Okay, I mean, if we were nervous before, this is a whole nother level. So rolled her into the trauma bay, started racemic epinephrine. She was on her second bout of racemic epinephrine. Her pressure was in the 40s over something. I don't remember the lower number. And it was go time. They had the anesthesiologist in, they had the ENT, they have a team approach for intubating kids at that hospital. So that team was there, and they were setting things up. And I just raised my hand and I said, "Hey, I know we have BiPAP. Can we try BiPAP on her? We're going to know in like 3 or 4 minutes if this is going to work." And the doctor looked at me. He's like, "That's actually a good idea." It told the therapist to start it, and then looked at me, could see my wife had scrubs on, but looked at me and said, "What is it that you do?" So, because that's not normal, something that mom or dad will say, because that look that my wife gave me right before they started setting up CPAP or started setting up the intubation. I'll never forget that look. That look was, "Kyle, I mean, like, for the love of God, do something here." And that was just desperation. I mean, I'm not the answer, but it was just one of those things where I finally spoke up, because it wasn't until they started to intubate her that I realized that we needed to support her airway more than anything at that moment in time. So all of that slipped through the cracks for over an hour, like almost a 2-hour time frame from when I decided to take her to the urgent care to when we actually started putting CPAP on her, or bilevel on her, in the hospital. That was about a 2.5 hour period. So we didn't see how much she was declining because it was so slow over time. But it goes back to one of the things that you were talking about earlier, is like, when do they crump? Well, they hold on until they don't, and then when they don't, it's on, right? I told the doctor I was a respiratory therapist and a paramedic, and that my wife's a pediatric nurse, and he was like, "Oh, okay, so now I can talk shop with you." He brought us over, showed us all the numbers of all her blood work and everything, explained to us how severe she was, labeled septic shock with respiratory compromise. Everything except for organ failure was happening to her. Plus she had this group. So basically what he told us was that she was basically running a marathon, and then halfway through the marathon, she started having diarrhea and vomiting, and then kept on running. And that's why she was so depleted. So got her up to the ICU. My friend Rob, who was a paramedic for Westerville, who was one of the people who was the first department that we can find that started pediatric CPAP in the 911 setting. We're standing over, he looks down, he's like, "Why aren't we doing this in EMS?" And I said, "Well," and I dealt with protocols a lot back then, because I was a representative of of regular adult CPAP to get it implemented back then. And I said, "Well, protocols don't go lower than 16. And he's like, "But it works. Look." And I said, "Oh, plus we don't have that mask. That mask is a cool mask." She accepted it like no problem. Like there was no fight for her. Plus she was pretty depleted by that time. And then that was the end of it for a few years. And then he was having a training with his department, and one of the children's people came in about sepsis. And because he remembered Camden's situation being labeled septic, he asked the educator at that time, "Why aren't we doing pediatric CPAP? Would that help?" And the guy was like, "Yeah, it helps in the hospital all the time." And then he got a hold of his medical director, got a hold of some children's medical teams, and got a hold of the manufacturers to try to figure out how to make the parts and pieces fit for the equipment that we have, and then the rest is basically history. So that's the full story. The good news is Camden, did get discharged. She's a healthy college student, and who is actually, in nursing school now at Ohio State University. Sorry, the Ohio State University. And right. Got one more year left. And here's the thing, she's running a pediatric. She's going to be in a pediatric externship this summer. So
nice.
So she's kind of like, it's come full circle, and she remembers that day. Her essay for nursing school 4 years ago. I had no idea what she remembered, but when we read that essay, I had to stop like six times because I was like, oh my gosh, I'm like, I can't remember. I can't believe you remembered as much as you remember.
Yeah.
And what it made her feel that she was being supported, and the staff and just the decisions, instead of being knocked out, not remembering everything, or having the memory of being extubated. So a whole different path it did happen because we supported her non-invasively. And that's really the bottom line. That's why I get very passionate about it. I do my best to control my passion because sometimes I don't want it to come across rude, but it's one of those things where why aren't we doing this? Why isn't more departments doing this? It's simple. It's being done. All you have to do is just follow the bridge that we built, that we're giving everybody to show them how to implement it.
Yeah. Yeah. It's such a powerful story in the fact of, I think us as providers, we're known as being non-compliant and being, like we're like, oh, you're fine. Like we're not going to go to a facility. Right. But I think it just speaks to that bigger picture of looking at all of the components, right? You can't just look at one aspect of it, and the similar, with my daughter and her heart surgery, when we found her, first figured out something was going on. She was comfortably tachypnic. She was breathing super fast. And, at that time, I'm like, oh, kids breathe fast, right? It's that whole, just looking at that whole big picture. And like, I tried to talk myself out of it for the next 2 hours and go through all that. But it's like,
that's the curse. That's the curse of the medical provider right there.
Right.
We could have a talk just on that.
Yeah. It's like, oh, you know too much. You're overreacting, but sure enough, it ended up being that. And she had heart surgery a few days later. But yeah,
she doing okay now?
She's doing fantastic. Cool. So she's 12 now. Okay. She's since had a second procedure at age 9. But yeah, she's doing fantastic.
Good. That's awesome.
But yeah, so I appreciate you sharing that story. I think that just kind of speaks to the passion and where we're at and getting this going. And I think we also established that pediatric CPAP works and that using it earlier changes outcomes. But and knowing that, but actually getting it into the hands of providers on the street are two very different things, right? So let's talk a little bit about what it really takes to implement the pediatric CPAP in a system, because I think this is often where those good ideas stall out, right? And it sounds like you guys were able to push that through and actually get it into implementation. So for other agencies, you mentioned there's a lot of resources already built and available. So how do we share that or get people interested in getting this implemented?
Yeah. Well, I can provide you with a link that has a landing page that has the origin story video that talks a little bit like higher, more a little more simple versions of the full story that's on there. That has the equipment overview. It has a podcast or two that we've done. It has the protocol. You can click on and just see the protocol that was put together. So you don't have basically when we started this next phase, because like I said, we've been doing it for 7 years with success in Central Ohio, but we never had anything like that was truly organized in training. Our training was, this is how you put it on and this is how you recognize respiratory distress. Well, now we, with the podcast that we did back in November, that was 3 out of the 4 people of that podcast were part of the original team. The medical director which is also where I'm going to be heading here. Medical direction has to accept this. I mean, I'm not like, you got to do this. They're the ones that have to lead this. They have to realize that, okay, I get it that it's infrequent, but it's still going to be something that we can support it. And is it really that infrequent when you also classify that asthmatic patient? Because asthma, we all know that we do breathing treatments and CPAP or BiPAP on asthmatic adults. We do lower levels. We help stent that airway open. The medication gets deeper, more effective. You're not just nebulizing dead space, and that's more important when it comes to the kids. And Dr. Kadish, who is a medical director for a lot of the departments here in Central Ohio for peds specific, and she's a pediatric ER doc at Children's Hospital here in Columbus. Nationwide Children's Hospital here in Columbus. Got to make sure I do the full name. And one of the things she said on the podcast, and it actually surprised me when she said it, because I hadn't even gone there yet. I hadn't even gone to the fact that asthma patients are probably one of her what she mentioned was asthma patients are one of the most frequent used patients with CPAP because of stenting the airways open, getting that medication deeper, and being more effective. So if we think of that patient, that actually brings our numbers a lot higher of the potential of implementing this therapy. So, older kids that can actually suck on a nebulizer, and okay, that's one thing, although there's no PEEP behind it. There's no stenting the airways open to get it deeper. You're still relying on their inspiratory pressure to do it. That silent chest child that I just spoke about that happened with a team that we just had recently in the last few months, that was a silent chest patient. They started to wheeze eventually because we stented the airways open, or the team, I shouldn't say we, I wasn't part of it, but the team stented the airways open physically with the PEEP and the pressure, and we're able to plug in the nebulizer into the bottom, so that's where the implementation comes. When it comes to implementing this, first of all, the training is huge. I really suggest that if people think, oh, this would be great to do, and a medical director says, oh, this is great, yes, I think it'll work. We have a population that this could work on for sure. I want it there for our providers to have another answer for that work of breathing part of the triangle. If they buy into all of that, which is really where I emphasize all of my training now is on that, then when it comes to actually the physically doing it, that's the easy part. It's the changing, like you said earlier, it's changing of the mindset is the hard part. Once we change the mindset, then we can do it. And then we just need a couple of things to add to our toolbox to do it with. So.
Yeah, those are the bigger questions I had was, what is medical direction's role in this? And you hit on that. And then also, what does that training look like part? But I think another piece that I have is how do you build the confidence in providers who are hesitant to use CPAP on kids?
That comes with the training. That's the mindset change. That has to, that's where it really lies is, and I'm, my team is willing to do train the trainers. We know that there's very sharp individuals out there that can, we don't have to be the only people that train this. Now, would I like to train everybody in the nation on this? Absolutely. I would love to be the team that helps train everybody. But, someone like people like yourself and other high level educators that understand, they get the concepts, they know what PEEP does, they know what it does for adults. There could be a train the trainer where it just basically helps reorganize the thought process and how to walk that reluctant, provider through the path, because that's what all good training is built on, walking them through a path of doubt, denial to, maybe this could work, to acceptance, to implementation. And if you don't walk that person through that, like we didn't just throw in high performance CPR into our system and just say, okay, just do it. Just don't pause. Make sure you recoil properly. Make sure you breathe right. No, we had a huge 3-month situation where we trained the trainers. We took that education out to every single individual in the county, and we trained them hands-on, showed them the science behind it. That's one thing when it comes to the science. The science is already accepted of what CPAP does to a lung and how it stents it open. That science is there. We just have to convince them and show them that it's no different with pediatric patients. And there's all kinds of, papers and stuff about CPAP in the hospital setting. And it's no different than that, because it's the PEEP is PEEP. And once we walk them through that path of education, that provider who was doubtful or reluctant should if we do it right, if we do the training right, and we teach them in the proper order, and that we have an answer for work of breathing now, and we have an answer for them. The biggest one, the second biggest thing that people say is, oh, that kid's not going to tolerate that mask. That kid's not going to. Well, if that kid is fighting you that hard about putting a mask on, then maybe they don't need it. Okay. But the kids that we've seen that have accepted it are like, oh gosh, thank you. They may not say it, but they get it. They start realizing that they're breathing easier.
Yeah, absolutely. I think that kind of brings us. Do you have the mask that you could show and just kind of demonstrate what that looks like? Because I think it's different than what we're typically expecting or used to with CPAP. Right?
Exactly. Most people, when they think of CPAP, especially for the adults, now don't get me wrong, the total face mask for adults are out there. Actually, one of the bigger sizes is actually called the adult small. But most of these masks aren't this. Now, could you do this type of mask on a teenager? Absolutely. Some teenagers are as big as myself and you. And some teenagers are as small as little old women. We still put CPAP on them, right? So it's not just about this. The true and you're okay if you're once a department goes with pediatric CPAP and that pediatric age limit of 18 or less, or 17 and 365 almost days, whatever that is, if you want to do the old fashioned one for them, that's fine. But when you're talking about the toddlers and the babies, that's where the total face mask comes into play. And when I say total, because what's really weird in the industry is this is called a full face mask, because we've got nasal pillows. So nasal pillows, full face mask, total face mask. So the total face mask, this is actually the adult small, and it looks like an SCBA. It has a swivel adapter on it that fits not with the right adapter. This fits the large bore the large bore CPAP devices like the GoPAP and like the O2 Max are large bore CPAP generators is what I call them. Then all the other things would fit in here. Your flow safe, your ventilator circuit would fit in here like normal. Okay, and if this mask looks familiar to you, if you're running a T1 ventilator in your system and you have the Hamilton, a mask that Hamilton provides for you, this is the total face mask that they provide. It's no different. It's the same one. So this is where this is one of the things that makes it work for the other systems. Everything else fits in here. So we've figured out what parts and pieces make it work. That Apollo 13 thing where we need, and this is, think about your CPAP. Think about your PEEP valves on an ambu bag. Some PEEP valves come with this adapter to fit on the large bore exhalation ports of a BVM. So this is no different than having it, having the right adapters to make it work for whatever your system has. So this is the adult small. That's what that looks like. Then there's it's really complicated. It's extra small or extra small, and those both look like this. One's a little bit more of that other shape, and this has got the bonnet on it too. This is actually comes with it to hold it on, but this is the shape of the extra small, and then the shape of the extra small is a little bit more panned out for your babies, but it still has this swivel adapter on it, which is actually really nice. So let's say we are doing a nebulizing on a patient that's really small, and we are using a device like this, and then you're like, okay, well, how do I nebulize that? Well, mom and dad now have something to do, holding that baby in their lap and holding it off to the side. And holding that off to the side puts this in the proper position to nebulize properly, and it keeps it from not touching their chest, because there's still masks on a baby. You see what I mean? So we actually kind of stumbled across one of the original masks that we used, which was a different configuration. It was actually bumping the little girl's chest, and it was not allowing for upright of nebulization. So we kind of had to kick it over to the side. Well, this automatically gives us a chance to do that. Your ventilator circuit, here's a sample ventilator circuit. It fits whether it's the elbow that fits it inside of there, or whether it's direct and you take the elbow out, it still fits it. So this is the one-stop shop mask with an adapter that I was told recently that they're going to start doing something to package this with each mask so it can accommodate. And that's really it. Whatever CPAP device you're using in your system, this is all you need. You don't need to get a whole new CPAP generator or driver, whatever you want to call it. If you're
Yeah.
using the yellow box, the emergent yellow box, that all fits too. Instead of plugging that emergent circuit into that yellow sponge mask, you plug it into the blue adapter for that child. It's still PEEP is PEEP, flow is
Yeah.
flow. I'm trying to think what else that you need. I mean, when it comes to the nebulizer, you do need that little green adapter, because most nebulizer, I mean, really the T1 runs off its own nebulization port, but the green adapter that attaches, your oxygen tubing to your nebulizer, and you run that off of 50 psi, and this gives you 6 to 8 liters of nebulization.
Gotcha.
That's really all you add. And then, of course, my department and other departments that have this, they include a capnonasal cannula, they include the nebulizer, they include the 3 different masks, and whatever CPAP generator driver they're using, and still follow the rules of what that device tells you how to turn things on and what flow rates. With the GoPAP, it's 10. With the flow safe, the flow safe, you've got the book that you have to read and figure out if you're on bi-level or CPAP, and decide what to do with that, and make sure you're reading the proper side. But you follow all the same instructions, because once again, PEEP is PEEP. You're just trying to figure out where, what your PEEP is. This is the flow safe. So if someone out there watching this has a flow safe, well, how does that fit in? It fits into the mask the same way, just without that adapter. It just fits inside of it. Yep. Sorry, go ahead. I just wanted to show that.
No, that's okay. Yeah, I think the 2 questions I have, I think you essentially answered the one, but just to say it out loud, the first one is there a minimum age or like a stopping point that you can't go down to? And then the second one is, as far as settings go, does that change based off of size and age, or are we looking at the same targets?
You're looking at basically all the same targets, and you'll have to follow your state's protocols for age. We here in Ohio, that's where I'm at. And if you just recently saw February 19th, it'll day that'll live in infamy for me, because that is when we finally have language inside of our state protocol that states that basically it talks about CPAP and BiPAP, and it says any age level. But your state medical direction, if you don't have wordage that talks about age, none of them say that I've been able to find. Protocols may say only to age 16, so that has to be changed. But then that scope of practice above the protocol level for the state also has to be dealt with. And it's really one of those things where we do, there's stuff. Dual sequential, defibrillation is not really in everybody's protocol, but a lot of people are not protocol, but state scope of practice, but they're doing it, right? It's that off-label thing. So, I mean, this is the part, like, we can't change what the wordage says until we have departments and we have states that actually start putting wordage in. So you can look up the state of Ohio's scope of practice and see what their wordage is if you live in a state that needs some change and needs to be able to address the age group. Basically, we know that CPAP gets used on even the brand new babies in the NICU. So the smallest of the small can go on CPAP. And so there really is no age limit. And really the only contraindication, because, that's one thing we always want to talk about with CPAP is, they have to be holding their own airway. They can't be apneic, and they can't be actively vomiting. They can't have face anomalies. And then the last one is if the mask fits. So,
yeah.
I've taken the smallest dummies that I could find in our training department, and it totally, the smallest mask will fit on that child, in that way of below the bottom lip and above the eyes. If it rides up their forehead, okay, it rides up their forehead. No big deal. So, and there's a sizing chart that is used for figuring out if it's one of the 2 smaller ones. And if it's not one of the 2 smaller ones, because those sizing charts puts it through the middle of their eyes or not high enough on their forehead, then you just bump up to the adult small, which then could ride up the forehead if it has to get a good seal.
Yeah. No, I think that's great. So, yep, Kyle, I mean, I think this was absolutely outstanding. And I think what you did today was take something that a lot of providers just feel unsure about and turn it into something that's clear, practical, and actionable. And at the end of the day, this isn't just about CPAP. It is about recognizing sick kids earlier, intervening sooner, and then changing those outcomes before they ever reach the hospital. So I truly appreciate the work that you're doing. I appreciate you being here today. And for everyone listening, if this episode made you think a little bit differently about how you approach those pediatric patients, and then we're doing exactly what we set out to do here today. So this is the Reducing the Pucker Factor. And Kyle, before we close things out here, can you please tell the listeners where they can find you and any final departing words that you have for them?
Sure. You can find me pretty much any Google search if you spell my last name properly. Kyle Goodnight, Goodnight. Don't forget the K. That's important. I have all of my websites and all of my podcasts that I run are on those in that search. There will be something I'm going to provide Chris with a link to the landing page for the Pediatric CPAP project. It's an ebook, and it's got everything. I mean, it's basically everything you heard today is actually essentially reiterated in that ebook, and it also has the equipment that you can look up and see exactly where to get them and whatnot. It also has videos of showing the equipment again in a little bit different setting instead of just in front of the camera, and it also has the origin story and a little bit of the training inside that ebook. The ebook is and it has the protocol. So the ebook has the protocol that you can look at the protocol, see that we brought work of breathing up to the top of the assessment tree inside the protocol. That's one of the first things that we start talking about. And on the indications of starting pediatric CPAP, work of breathing is above pulse oximetry as well. So you can, of course, it's just a sample protocol. Your medical direction has to either one, sign off of it or translate it to your format or what have you, but it's there. Recreating the wheel is something we didn't want every department in the country to have to do if they wanted to implement this. So we've provided a path. We've provided basically a bridge over all the pitfalls that we have learned from the beginning of the project. So, yep.
Yeah. Awesome. Well, thank you so much. Appreciate it.
You're welcome. Anytime. Thanks for having me. I appreciate it.
Yeah. The call goes out and the crew's on the move. Lights up, crew locked in, yeah, we know what to do. Their hearts beating fast in the back of the rig, but we don't panic, nah. We're dialed in big. Scenes chaotic, kids sick, but we're right on track. We breathe deep, lean in, bring the calm right back. We're reducing the pucker factor, turning fear into confidence. From the med unit to the helicopter, bring the calm when the chaos won't stop. Yeah, we're the bakery content crew, showing what the pros can do. Turn the fear into calm under pressure. Pucker factor, gone forever. Pucker factor, gone forever. Yeah. Got skills, got data, got a plan that hits. Got the airway game strong and the trauma kids. Yeah, from scene to scene, we're raising the bar. EMS super nerds, yeah, that's who we are. Hey! For the medics in the front line, let's go. For the flight teams on the lifeline, let's go. For the ones who are running faster, we're reducing the pucker factor. We're reducing the pucker factor, turning fear into confidence. From the med unit to the helicopter, bring the calm when the chaos won't stop. Yeah, we're the